Hook. The smaller twin wasn't breathing. His chest lay still against my trembling hands, skin cooling under the harsh fluorescent lights of the delivery room. Around me, voices overlapped in urgent commands. Nurses calling for medications, the attending physician barking orders at the neonatal team clustered around the isolette where his brother fought for air. But all I could hear was silence, the terrible, suffocating silence where a newborn's cry should have been. Dr. Reyes. Dr. Patricia Chen's voice cut through the chaos. My supervising physician stood across from me, her eyes meeting mine over her surgical mask. Let him go. 3 words. Simple, clinical, final. I looked down at the infant in my hands. He weighed less than 2 pounds. His translucent eyelids were fused shut, his ribs visible through paper-thin skin. 23 weeks gestation. The textbooks called this the gray zone, the murky territory where medicine meets mortality, where every intervention could be salvation or suffering. Dr. Reyes, Chen repeated, firmer now. We need to focus our resources on the viable twin. But what she didn't know, what none of them could see in that moment, was what would happen if I disobeyed. 3 months earlier, I'd walked through the doors of Hospital St. Halsted for the first time as a resident, not a student. The building rose 12 stories above the fictional city of Riverside Falls, its glass facade reflecting morning light like a beacon. Inside, the lobby smelled of antiseptic and coffee, sounds echoing off marble floors, the squeak of gurneys, the digital chime of elevators, the constant murmur of lives in crisis. I was 27 years old. My white coat still had crisp creases from the package. The embroidered text over my heart read, Noah Reyes, MD, internal medicine resident. My parents had flown in from Houston for my first day. Mama kept adjusting my collar, her hands shaking slightly. Papa stood back, trying not to cry, failing. They'd worked double shifts at the restaurant for years to help me through medical school. Every late night studying, every exam passed, every doubt overcome. It was for them as much as for me. You're going to save lives, mijo, Mama whispered, kissing my cheek. I wanted to believe her. The internal medicine residency at St. Halsted was competitive, 40 applicants for every position. The program director, Dr. Marcus Webb, was legendary, a diagnostician who could read patient charts like poetry, who taught residents to think 5 steps ahead. During orientation, he'd stood before our cohort of 12 new residents and said something that stuck with me. Medicine isn't just science, it's storytelling. Every patient is a narrative waiting to be understood. Your job is to listen to the story their body is telling, and sometimes to hear what they cannot say. I'd nodded along with everyone else, scribbling notes, eager and terrified. My first rotation was labor and delivery. Not typical for an internal medicine resident, but St. Halsted cross-trained us in multiple departments. You'll see everything that can go wrong with the human body here, Dr. Chen had said during my first shift. Pregnancy stresses every organ system. If you can handle obstetrics, you can handle anything. Dr. Patricia Chen was 52, with silver-streaked hair pulled back in a tight bun, and the kind of calm that only comes from 2 decades of delivering babies. She'd seen thousands of births, routine deliveries, emergency C-sections, stillbirths, miracles. She moved through the ward with the confidence of someone who knew exactly where every instrument was, every protocol, every possible complication. I shadowed her like a lost puppy those first weeks. The labor and delivery ward occupied the entire 4th floor. The walls were painted soft blue, an attempt at calm that couldn't quite mask the underlying tension. Every room had monitoring equipment, crash carts, neonatal warmers. I learned to read fetal heart rate tracings, to recognize the subtle signs of distress, to know when a mother's smile was masking fear. Most shifts were routine, contractions, dilation, pushing, crying, joy. I'd hold newborns still wet from birth, their fingers curling around mine, and feel something profound I couldn't name. Life beginning. Simple as that. But not all stories ended that way. I learned that fast. My second week, I witnessed my first stillbirth. A mother who'd carried her daughter to full term, felt her moving that morning, arrived at the hospital with excitement and anticipation. But somewhere between the parking lot and the delivery room, the baby's heart had stopped. Just stopped. No warning, no explanation. One moment there was life, and the next there wasn't. I stood in the corner of that delivery room, watching Dr. Chen deliver a silent infant, watching the mother's face transform from confusion to understanding to devastation. The father collapsed into a chair, his whole body shaking. Dr. Chen handled it with grace I couldn't fathom. She wrapped the baby in a blanket, placed her in the mother's arms, gave them time to say hello and goodbye in the same breath. Later, in the break room, I'd asked Chen how she did it, how she moved from that room to the next delivery, from death to life, without breaking. "You never get used to it," she'd said quietly. "The day you get used to it is the day you should quit, but you learn to carry it. You learn to honor what you couldn't save by fighting harder for what you can." Those words had stayed with me. Her name was Emma Cartwright, 29 years old, pale skin dusted with freckles, red hair pulled into a messy ponytail. She arrived at St. Halstead on a Tuesday morning, 23 weeks pregnant with twins, bleeding. I was reviewing charts in the residence station when the call came through. Premature labor, twin pregnancy, active hemorrhage, prep OR2. Dr. Chen grabbed her tablet and headed for the elevators. Reyes, with me. We moved fast. The obstetrics operating room was on standby, lights already blazing, the neonatal intensive care team assembling. I could hear Emma before I saw her. Sharp, pained gasps echoing down the corridor. She was on a gurney, her husband Daniel gripping her hand, his face drained of color. An IV line ran into her arm, fluids dripping. Her hospital gown was stained dark red. 23 weeks, Dr. Chen murmured, reviewing the ultrasound images on her tablet. Monochorionic diamniotic twins. Twin-to-twin transfusion syndrome. I knew what that meant. Identical twins sharing a placenta, but unequal blood flow between them. One twin, the recipient, gets too much blood, straining their heart. The other, the donor, gets too little, starving. Without intervention, both often die. "We tried laser ablation at 20 weeks, Emma gasped between contractions. "They said it worked, they said..." She cried out, her body seizing. Dr. Chen checked the fetal monitors. 2 heartbeats, both erratic. "They're in distress. We need to deliver now." "But they're too early," Daniel said, his voice breaking. "They're not ready. They'll die if they stay inside," Chen said, not unkindly. "This gives them a chance. A chance." That word hung in the air like a prayer. I helped wheel Emma toward the OR, my mind racing through everything I knew about extreme prematurity. 23 weeks, 17 weeks before full term. Babies born this early had lungs barely capable of gas exchange, brains vulnerable to bleeding, immune systems incapable of fighting infection. The survival rate hovered around 40%. And among survivors, the rate of severe disability was staggering. But 40% wasn't zero. We wheeled Emma into the OR. The anesthesiologist worked fast, administering a spinal block. Nurses prepped the surgical field, painting her abdomen with antiseptic, draping sterile sheets. I scrubbed in beside Dr. Chen, my hands shaking slightly as I tied my surgical gown. "You're observing today," Chen said quietly. "But stay ready. Things can change fast." I nodded, taking my position across from her. The room hummed with controlled energy. The neonatal team had 2 complete setups ready, isolettes with radiant warmers, ventilators on standby, medication trays arranged with precision. I recognized Dr. Sarah Martinez, the lead neonatologist, conferring with her team in low voices. The scalpel touched skin, blood welled. Chen worked with practiced precision, through skin, through fascia, through muscle, reaching the uterus. The membrane bulged, taut and translucent. "First twin," someone called. The neonatal team stood ready, 2 isolettes waiting, 2 sets of tiny instruments laid out. I'd never seen equipment that small. Intubation tubes thinner than straws, IV catheters barely visible. Chen made the final incision, and then everything went wrong. The first twin emerged blue, silent, impossibly small. The neonatologist grabbed him, rushed him to the isolette, began resuscitation. Chest compressions with 2 fingers, oxygen mask covering his entire face. "Second twin, breech presentation," Chen said, her voice tight. "Breech, feet first. Complicated. Dangerous." She reached inside, her hands moving with controlled urgency. I could see the tension in her shoulders, the way her jaw clenched. Time stretched. The monitors beeped faster, more insistent. "Come on," Chen whispered. The second twin slid free, smaller, so much smaller. His skin was almost translucent, veins visible like rivers on a map. His chest didn't move. No cry, no gasp, just stillness. Chen laid him on the sterile drape between us. I stared down at him, a human being who weighed less than a bag of flour. fingernails like grains of rice, eyes fused shut, not ready to see the world. His limbs were stick-thin, no subcutaneous fat, just skin stretched over fragile bones. "Heart rate?" Chen called. The nurse with the stethoscope pressed it against the tiny chest, listened, moved it, listened again. She shook her head. Nothing detectable. Across the room, the first twin was being intubated. His heart rate was climbing. 50, 60, 70. The neonatologist's hands moved in controlled rhythm. Breathe, compress, breathe, compress. But the second twin? Dr. Chen looked at the monitors, at the baby, at the chaos unfolding around us. She made a calculation I could see forming in her eyes. Resources, odds, priorities, the brutal mathematics of emergency medicine. "Dr. Reyes," she said quietly, "let him go." I felt the words land in my chest like a stone. "We need to focus our resources on the viable twin," she continued. 23 weeks, donor twin, severe growth restriction, no heartbeat detected. But the word escaped before I could stop it. Chen's eyes met mine over her mask. "I know what you're thinking, but you need to understand something. Not every life can be saved. Sometimes the kindest thing we can do is minimize suffering. This baby," she gestured to the still form between us, "he's been compromised for weeks. Even if we got him back, the likelihood of meaningful survival is essentially zero." The second twin lay between us, still, silent, fragile as glass. And I thought about my mother's words, "You're going to save lives." I thought about Dr. Webb's lesson, "Listen to the story their body is telling." I looked at this tiny, translucent infant, at the subtle flush still visible beneath his skin, at the way his fingers curved slightly, as if reaching for something. And I saw something that Dr. Chen didn't see, or couldn't see, or had trained herself not to see after 20 years of impossible decisions. I saw a person, not a set of statistics, not a doomed case, not a resource allocation problem, a person whose story hadn't been told yet, and I made a choice. I picked him up. The weight of him barely registered in my hands. I could feel the delicate architecture of his ribcage, the flutter of something that might have been a pulse, or might have been my own heartbeat transmitted through my fingers. "Dr. Reyes!" Chen's voice held a warning, but I was already moving. The second neonatal isolette stood empty, its warming lights glowing orange. I carried the twin across the OR, my hands supporting his head, his body. A nurse stepped aside, surprise flickering across her face. I laid him down on the warming pad, the heat immediately radiating against his translucent skin. "Get me a bag mask," I said. My voice came out steadier than I felt. The nurse hesitated, glancing toward Dr. Chen. "Now," I repeated, my tone leaving no room for debate. She handed me the neonatal resuscitation bag, a tiny balloon connected to a mask designed for premature infants. I positioned it over the baby's nose and mouth. His face was so small, the mask nearly covered it entirely. I began to squeeze. One breath. The chest rose, barely, just a millimeter, but it rose. 2 breaths. 3. "Reyes." Dr. Chen appeared beside me, her surgical gloves still bloody from the delivery. "What are you doing?" "CPR," I said, continuing the rhythm. "He's 23 weeks. That's viable. We've had survivors at—" "He's the donor twin," Chen interrupted. "Look at him. He's severely growth restricted, likely has organ damage from chronic hypoperfusion. His body weight is probably under 500 grams. Even if we get him back, the likelihood of severe disability, cerebral palsy, blindness, cognitive impairment, is astronomical. Is not 100%, I said, placing 2 fingers on his sternum. My fingers looked enormous against his chest. I could feel his breastbone beneath the skin, fragile as a bird's. I began compressions, gentle, controlled, following the rhythm drilled into me during neonatal resuscitation training. 30 compressions to 2 breaths. Breathe, breathe, compress, compress, compress. Across the room, the first twin was stabilizing. I could hear the neonatologist calling out vital signs. Heart rate 85, oxygen saturation 62 and climbing. We've got good chest rise, preparing to transport to NICU. But here, in my hands, nothing changed. The second twin remained still. No gasp, no movement, just the mechanical rise and fall of his chest as I forced air into his lungs. "How long are you going to do this?" Chen asked quietly. I didn't answer. Couldn't answer. In medical school, they teach you about futility, about recognizing when interventions cause more harm than good, about the ethics of withdrawal of care. I'd sat through lectures, written papers, debated hypotheticals with classmates over coffee, but this wasn't hypothetical. This was a human being in my hands. Tiny? Yes. Fragile? Absolutely. With odds stacked impossibly against him, but human. Undeniably, irreducibly human. "One more minute," I said. Chen didn't argue. She stood beside me, watching, her expression unreadable behind her surgical mask. I could feel her judgment, her concern, her uncertainty about whether to stop me or support me. I kept going. Compress, compress, compress. Breathe, breathe. The monitors around us beeped steadily. Emma's vital signs, the first twins improving stats, the ambient hum of machines keeping people alive. 30 seconds passed. 45. My arms ached. Sweat gathered at my temples, threatening to drip into my eyes. "Reyes!" Chen's hand moved toward my shoulder, and then I felt it. A flutter under my fingers. Faint. Irregular, but unmistakably there. "I've got something," I whispered. The nurse moved in with a stethoscope, pressing it against the tiny chest. Her eyes widened. Heart rate. 20, 30, 40. "Keep going," Chen said, and suddenly she was beside me, her hands moving with mine. "Get me an umbilical line kit. We need vascular access. And call respiratory. Tell them we need a second team up here stat." The room shifted. What had been a quiet corner of the OR exploded into controlled action. Nurses brought equipment. The second neonatologist joined us, hands already gloved. Someone called for medications. Epinephrine, sodium bicarbonate, dextrose. "Heart rate 50, the nurse announced. I kept bagging, kept breathing for him, watching his chest rise and fall with each squeeze. 60. Chen inserted a tiny catheter into his umbilical cord. A vein barely visible, thinner than a piece of thread. Her hands moved with absolute precision, years of experience guiding every movement. "Epinephrine ready," a nurse said, drawing up the medication in a tuberculin syringe. "Give 0.1 milliliters, Chen ordered. "Slow push." The medication flowed through the umbilical line. We waited. Seconds felt like hours. 70. The baby's skin shifted subtly, from blue-gray toward pale pink. Not healthy pink, but better. His fingers twitched. 75, 80. And then, so faint I almost missed it, a sound, not a cry, too weak for that, but a gasp. A tiny, desperate gasp that spoke of lungs filling with air for the first time. He was breathing. Not well, not enough, but breathing. "Get him intubated," Chen said, her voice tight with focus. "Size 2.5 tube, and someone check a glucose. He's probably hypoglycemic." The neonatologist moved in with a laryngoscope, the blade smaller than my pinky finger. She inserted it carefully, visualizing the infant's airway, a space so narrow, so delicate, that one wrong move could cause catastrophic trauma. "I see the cords," she murmured. Tube going in. The endotracheal tube, barely thicker than a strand of spaghetti, slid into place. She secured it with tape, connected it to the ventilator. The machine took over, pumping oxygen into developing lungs at a rate of 60 breaths per minute. "Heart rate stabilizing at 90, the nurse called. I stepped back, my hands shaking. The baby, this tiny, impossible fighter, lay under the warming lights, tubes, and wires connecting him to machines, his chest rising and falling in mechanical rhythm. Dr. Chen looked at me, her eyes unreadable. "You just committed us to a very difficult road." I nodded. I knew. 23 weeks gestation. Severe growth restriction. Uncertain neurological outcomes. Months in the NICU. Possible blindness, cerebral palsy, chronic lung disease, a lifetime of complications. Or a lifetime. "We should tell the parents," I said quietly. Emma was still on the operating table when we approached, the surgical team meticulously closing her incision layer by layer. Her eyes were closed, whether from exhaustion or sedation, I couldn't tell. Her husband Daniel stood nearby, still in his visitor scrubs, his face a mask of terror and hope warring for dominance. "Both twins are alive," Dr. Chen said without preamble. Daniel's knees buckled. A nurse caught him, guided him to a chair. "They're extremely premature," Chen continued, her voice clinical but not unkind. 23 weeks. They'll need intensive care for months. Twin A, the larger one, is currently stable but critical. He's been intubated and is being transferred to the NICU now." "And the other one?" Daniel asked, his voice barely above a whisper. Chen paused, choosing her words carefully. "Twin B required extensive resuscitation. He had no detectable heartbeat at birth. Dr. Reyes, she gestured to me. Dr. Reyes initiated CPR against my recommendation. He brought him back. Daniel looked at me, his eyes searching my face for, what? Certainty? Hope? Permission to feel relieved? You need to understand, I said gently, carefully, that we don't know what the outcomes will be. Both twins face serious complications, but twin B especially. He's smaller. He's been compromised by the twin-to-twin transfusion. There could be serious disabilities, developmental delays. We're talking about babies born 17 weeks early. But they're alive, Daniel said, and it wasn't a question. Right now, in this moment, they're alive. Yes, Chen confirmed. Then that's enough, Daniel said. For right now, that's enough. Emma stirred on the table, her eyes fluttering open. My babies? She murmured, still foggy from the spinal block. Daniel moved to her side, took her hand. They're here. They're both here, love. Emma's face crumpled, tears spilling. I want to see them. Soon, Chen promised. Once you're stable and they're settled in the NICU, we'll arrange it. But Emma, you need to prepare yourself. They're very small, very fragile. They don't look like the babies you've been imagining. I don't care what they look like, Emma said fiercely. They're mine. The twins were transported to the neonatal intensive care unit in separate isolates, each pushed by a team of nurses and respiratory therapists. I followed them upstairs, unable to stay away, needing to see what happened next. The NICU was a different world. Dimmed lights to protect developing eyes. The constant symphony of ventilators and monitors. Isolates lined up in rows, each containing a fragile life suspended between existence and void. Twin A, the larger one, though larger meant 1 pound 14 ounces, was already settled in. His ventilator settings were being adjusted, his IV lines secured. The nurses moved around him with practiced efficiency, checking monitors, adjusting temperatures, documenting every vital sign. Twin B weighed 1 pound 6 ounces. I stood beside his isolette, watching the tiny chest rise and fall in sync with the machine. His skin was so thin I could see his heart beating through his ribcage, a rapid flutter, working overtime to perfuse a body that wasn't ready to exist outside the womb. Every bone was visible. His head was smaller than my fist, covered in fine hair called lanugo that wouldn't have shed for another several weeks in utero. First time? A voice beside me. I turned. Dr. Sarah Martinez, the neonatologist who'd intubated twin B, stood with a tablet in hand. She was in her 40s, with kind eyes that had seen too much, and the kind of tired that comes from years of keeping impossibly small humans alive. First save, I admitted. Some would debate the word save, she said, not unkindly. What you did in that OR was give him a chance. What happens next? She gestured to the isolette, to the machines, to the fragile life suspended in medical technology. That's a long story we haven't finished writing. Do you think I made the right call? Dr. Martinez was quiet for a moment, studying the monitors. Heart rate, oxygen saturation, respiratory rate, blood pressure measured through an arterial line thinner than thread. Ask me again in 3 months, she said finally. Right now, all I can tell you is that this baby is alive because you refuse to accept the alternative. Whether that's right or wrong depends on what comes next. And we won't know that for a long time. She pulled up his chart on the tablet, began reviewing the delivery notes, the APGAR scores, a grim one at 1 minute, a slightly better 4 at 5 minutes, and the initial lab work. Glucose is low, as expected. We're running dextrose. Hemoglobin is adequate for now. Electrolytes need monitoring. We'll get a head ultrasound in the morning to check for bleeds. She looked up at me. You understand the risks, right? Grade 3 or 4 intraventricular hemorrhage, paraventricular leukomalacia, necrotizing enterocolitis, retinopathy of prematurity, chronic lung disease. The list goes on. I understand, I said. Do you? Martinez asked, and there was no judgment in her voice, only curiosity. Because understanding intellectually and understanding viscerally are two different things. You'll watch this baby struggle. You'll see him in pain. You'll wonder if every intervention we do is helping or just prolonging suffering, and you won't have easy answers. I looked at Twin B, at his impossibly small fingers curling and uncurling in reflex, at the ventilator breathing for him, at the IV lines feeding him. I know, I said quietly, but I also know that if I'd let him go in that OR, he'd definitely be gone. This way, at least there's a possibility. Martinez nodded slowly. Possibility. That's what we deal in here. Slim possibilities and uncertain outcomes. She closed the tablet. I'll see you on rounds tomorrow, Dr. Reyes. Try to get some sleep. This is just the beginning. I started spending my off hours in the NICU, not officially assigned there, not required to be there, but I couldn't stay away. Every morning before rounds, I'd stop by Twin B's isolette. The nurses had started calling him Baby Cartwright B on the charts, but I'd overheard Emma and Daniel whispering possible names through the isolette's portholes during their visits. Lucas, Michael, James. They couldn't hold him yet. Too fragile, too unstable. But they'd slip their hands through the portholes and rest their fingers against his skin. Kangaroo touch, the nurses called it. Human contact for a baby born too soon to understand it but needing it nonetheless. Twin A, whom they'd named Ethan after Daniel's grandfather, was doing better. Still critical, but his oxygen requirements were dropping steadily. His weight was stabilizing. Small victories measured in grams and percentage points. Lucas, they'd finally decided on Lucas after Emma's father, was struggling. Day 3, respiratory distress worsened. Ventilator settings increased. Higher pressures, more oxygen, faster rate. Day 5, suspected infection. Blood cultures drawn. Broad-spectrum antibiotics started while we waited for results. Day 7, a brain bleed. The morning head ultrasound showed blood in the ventricular system. Grade 2, not catastrophic, not the massive grade 4 bleeds that guaranteed severe cerebral palsy, but not good, not reassuring. I watched the updates on the charts, my stomach churning with each new complication. Dr. Chen's words echoed in my mind, gaining weight with each passing day. You just committed us to a very difficult road. During morning rounds with the internal medicine team, I presented Lucas's case. Dr. Webb listened intently, occasionally asking penetrating questions that made me reconsider what I thought I knew. "What's his prognosis?" Dr. Webb asked. "Uncertain," I said, pulling up the latest labs on my tablet. "Multiple organ systems are immature. The brain bleed complicates neurological outcomes. He's had one suspected infection so far. Respiratory status is tenuous, but..." I paused. "He's fighting." "Fighting," Webb repeated, his gray eyebrows raised. "That's an interesting word choice. Does the patient have agency in this scenario, or are we the ones fighting?" I thought about that question, about Lucas's tiny hands that would curl around my finger when I did cares through the isolette portholes, about the way his heart rate would spike when Emma sang to him, the monitors picking up his response to his mother's voice even through the plastic barrier, about something I couldn't quite define but felt certain existed. "Both," I said finally. "We're providing the medical interventions, yes, but there's something in him, some will to survive, that we can't manufacture. You can see it in how he responds, how he rallies when everything says he should crash." Webb nodded thoughtfully. "Remember what I told you during orientation. Every patient is a narrative waiting to be understood, but sometimes we're so focused on the medical narrative, the labs, the imaging, the interventions, that we forget the human one, the story of who this person is, what they're experiencing, what they're fighting for. He's 2 weeks old," one of the other residents pointed out. "Can we really talk about him fighting for anything? Can we really say he's not?" Webb countered. "We don't fully understand consciousness, especially in premature infants, but we know they respond to pain, to comfort, to their parents' voices. They're not passive recipients of care, they're active participants in their own survival." Week 2 brought a new crisis. I was in the residence lounge, halfway through a sandwich I'd forgotten to eat during a marathon clinic session when my pager went off. The number was instantly recognizable. NICU. Code status. My sandwich hit the table. I ran. The NICU was controlled chaos when I arrived. Nurses clustered around Lucas's isolette in Bay 4. Alarms screaming, high-pitched, insistent, terrifying. Dr. Martinez was at the bedside, her hands moving with controlled urgency, her face set in grim concentration. "What happened?" I asked, breathless from the sprint up 4 flights of stairs. "Spontaneous pneumothorax," Martinez said without looking up. His left lung collapsed. I could see it on the X-ray displayed on the monitor above the isolette. Lucas's left lung, tiny, underdeveloped, barely larger than a walnut, had ruptured. Air was escaping into his chest cavity, accumulating in the pleural space, crushing the already compromised lung tissue. His oxygen saturation was plummeting, 70%, 65. "We need to place a chest tube," Martinez said. "Now, get me the microthoracostomy kit." A nurse rushed to the supply cart. Another nurse was bagging Lucas manually. squeezing oxygen into his one functioning lung, while the ventilator alarmed uselessly. Martinez prepped the equipment with lightning speed. A chest tube for a 1-pound baby was barely thicker than a strand of spaghetti. The procedure required absolute precision. Pierce the chest wall between the ribs, advance the tube just far enough to drain the air, but not so far as to puncture the lung or heart. One wrong move could cause catastrophic bleeding in a baby whose entire blood volume was less than 3 ounces. "Hold him steady," Martinez instructed the nurse at the bedside. I stood back, hands clenched, useless, watching, praying to a God I wasn't sure I believed in. Martinez swabbed Lucas's left chest with antiseptic, made a tiny incision between his ribs, so small I could barely see it, inserted a trocar, guiding it with practiced precision through tissue paper thin. Air hissed out. Immediate decompression. She threaded the tube, secured it with sutures finer than thread, connected it to underwater seal suction. "Heart rate stabilizing," a nurse called. On the monitor, Lucas's lung began to re-expand. The collapsed white area on the X-ray slowly filling in with the gray that meant air, meant function, meant breath. Martinez secured the tube with additional sutures and sterile dressing. Her hands were rock steady, but I could see sweat beating at her temples. "Oxygen saturation climbing," another nurse reported. 70, 80, 85, 90. Crisis averted. For now. Martinez stepped back, stripped off her gloves, took a breath. "He's stable. For the moment." She looked at me. This is what we meant about complications. His lungs are so immature that the ventilator, the thing keeping him alive, is also damaging his lung tissue. It's a vicious cycle. Emma and Daniel arrived 20 minutes later, summoned by the NICU's standard protocol to call parents immediately when their baby codes. Emma's hands shook as she touched the isolette, her fingers finding the portholes by muscle memory. "Is he?" She couldn't finish the question. "He's stable," Dr. Martinez said gently but honestly. "But I want to be completely transparent with you. Lucas is facing complications we expected at his gestational age, but that doesn't make them easier to manage or less dangerous. His lungs are extremely premature. The ventilator that's keeping him alive is also causing something called bronchopulmonary dysplasia, chronic lung damage. Today he had a pneumothorax, a collapsed lung. We placed a chest tube. He's recovered, but this likely won't be the last crisis." "What are his chances?" Daniel asked quietly, his arm around Emma's shoulders. Martinez hesitated. I could see her calculating odds, weighing honesty against hope, trying to find the balance between preparing them for the worst and not crushing them completely. "At 23 weeks, baseline survival rates are around 40%, she said finally. "But Lucas has additional risk factors. The severe growth restriction from the twin-to-twin transfusion, the grade 2 brain bleed, the lung disease developing. If I had to estimate his chances of survival to discharge," she paused, "maybe 25%, maybe less." Emma's face crumpled. She pressed her hand against the isolette, against the plastic barrier separating her from her son. Daniel held her, his own eyes wet. I stood there, feeling the weight of my decision in the OR pressing down like a physical force. I'd brought Lucas back from nothing. I'd fought for this life. And now these parents were watching their tiny son suffer crisis after crisis, complication after complication. Had I done the right thing? Or had I just prolonged inevitable heartbreak? "But he's still here," Emma whispered through tears. "He's still fighting." "Yes," Martinez agreed softly. "He is absolutely still fighting." Week 3 brought a small miracle. Ethan was extubated. After 17 days on the ventilator, he was breathing on his own with just a nasal cannula providing supplemental oxygen. It was a major milestone, the first step toward eventually going home. Emma got to hold him for the first time during kangaroo care. The nurses helped her settle into the recliner, opened her shirt, placed Ethan, still impossibly small at just over 2 pounds, directly on her bare chest, skin to skin, his tiny body curled against her heartbeat. The photo Daniel took captured something transcendent. Exhaustion and terror and joy all braided together in Emma's expression. Love in its rawest, most vulnerable form. Lucas remained intubated. His weight had dropped to 1 pound 3 ounces. Babies typically lose weight initially, the nurses explained. Totally normal. Expected. Their bodies are adjusting to life outside the womb, to breathing, to the massive energy expenditure of simply existing. But Lucas's weight loss seemed steeper than expected, more prolonged. I started researching obsessively during my rare downtime. Medical journals, case studies, outcome data for extreme prematurity. I read about twin-to-twin transfusion survivors, about donor twins who beat impossible odds, about the neurological outcomes, the developmental delays, the quality of life questions. I read about the ones who died despite maximum intervention. The statistics were brutal. But statistics described populations, not individuals. Lucas was an individual. During a quiet night shift when I should have been sleeping but couldn't, I sat beside his isolette, watching the ventilator breathe for him. The NICU was dimmed for nighttime, most babies sleeping or resting, monitors beeping in gentle rhythm. "You're going to make it," I whispered to him through the plastic. "You have to." A hand touched my shoulder, making me jump. I turned. Chen stood behind me, still in her scrubs from a delivery, her surgical cap still on. "Can't sleep?" she asked, pulling up a chair. "Can't stop thinking," I admitted. Chen sat beside me. We watched Lucas together in silence for a long moment, watched the mechanical rise and fall of his chest, the numbers cycling on the monitors, the slow drip of nutrients through his IV lines. "I was harsh in the OR," Chen said finally, "when I told you to let him go." "You were being realistic," I said. "Maybe." She was quiet, her eyes fixed on Lucas. "I've been doing this for 20 years, Reyes. I've delivered thousands of babies. I've seen genuine miracles, babies who should have died walking out of this hospital healthy. I've seen tragedies that haunt me years later. And I've learned that sometimes the kindest thing we can do is recognize when we're causing suffering instead of preventing it." "You think I'm causing Lucas to suffer?" I said. It wasn't a question. "I think," Chen said carefully, "that you're very young and very idealistic, and you don't yet understand how heavy this work becomes when you do it year after year. Every life you save carries weight. You feel responsible for their future, their outcomes. But every life you can't save carries weight too. The what-ifs, the second-guessing, and sometimes," she looked at Lucas, at the tubes and wires keeping him tethered to life. "Sometimes the line between saving and prolonging death is very, very thin." I didn't have an answer for that. "But," Chen continued, her voice softer, "I also think you might be right. Maybe Lucas deserves this chance. Maybe 25% odds are enough when the alternative is 0. Maybe I've been doing this so long I've forgotten how to hope." She stood, squeezed my shoulder. "Just remember, whatever happens next, it's not your fault. You made a choice in an impossible situation. Now we see it through together." Week 4 brought an unexpected development that shifted the entire trajectory. Lucas's brain bleed hadn't worsened. The follow-up ultrasound showed it was actually resolving, slowly, but measurably. The blood was being reabsorbed, the ventricles returning toward normal size. Dr. Martinez called it encouraging and better than expected. His weight stabilized at 1 pound 4 ounces, not gaining yet, but not losing any more either. The chest tube was removed on day 22. The lung had healed completely. The X-ray showed full expansion bilaterally. Small victories, fragile progress measured in grams and millimeters, and single percentage points. I started to hope. My co-residents noticed my preoccupation. During our weekly didactic session, Dr. Webb pulled me aside. "You're getting attached," he observed. "I know. That's not inherently bad," Webb said. "Empathy makes you a better doctor. But you need to maintain boundaries. You can't take every case home with you emotionally, or you'll burn out before you finish residency." "How do you do it?" I asked. "How do you care without caring too much?" Webb smiled sadly. "If I figure that out, I'll write a book and retire wealthy. The truth is, you never fully master it. You just learn to carry it better." But week 5 shattered the fragile hope I'd been building. NEC, necrotizing enterocolitis. 3 letters that struck terror into every NICU parent's heart. I was post-call, finally sleeping, when my phone rang. "Dr. Martinez, you should come in," she said. "Lucas has developed NEC." I was out of bed and moving before fully processing the words. NEC is a catastrophic intestinal infection most common in premature infants. The intestinal tissue begins to die, literally necrotize, from bacterial invasion and inflammation. The abdomen becomes distended. The baby can't tolerate feeds. X-rays show dilated bowel loops, pneumatosis intestinalis, air in the intestinal walls where air should never be. If the intestine perforates, bacteria flood the bloodstream. Sepsis, organ failure, death. The only treatment is surgery. Remove the dead bowel before it kills the patient. Surgery on a 1-pound baby. The anesthesia alone could be fatal. The blood loss could be catastrophic. And even if the baby survived, removing large sections of intestine meant lifelong nutritional problems, possible short gut syndrome, years of complications. I arrived at the NICU to find Emma and Daniel already there, huddled together in the family consultation room. The pediatric surgeon, Dr. James Okafor, was reviewing Lucas's imaging with them. Lucas's tiny abdomen was visibly swollen. His skin had taken on a dusky color. The x-rays showed exactly what I'd feared. Dilated loops, air in the walls, the telltale signs of dying tissue. "We need to operate," Dr. Okafor was saying as I entered. He was a tall man with gentle eyes and hands that had saved countless children. "Remove the necrotic tissue before it perforates and causes septic shock." "What are the risks?" Emma asked, her voice hollow. "Significant," Okafor said honestly. "Lucas weighs 1 pound 4 ounces. Anesthesia at this size is extremely dangerous. The surgery itself will be operating on intestines the diameter of a pencil. Blood vessels thinner than thread. One wrong move." He didn't finish. Didn't need to. "What happens if we don't operate?" Daniel asked. "He dies," Okafor said bluntly. "The infection will spread. The intestine will perforate. Sepsis will develop. It's not a question of if, but when. Probably within 24 to 48 hours. And if we do operate?" Emma's hands were shaking. "He might die on the table. The anesthesia could cause cardiovascular collapse. He could bleed out. And even if he survives the surgery, recovery will be brutal. More time on the ventilator. Potential for short gut syndrome if we have to remove too much intestine. More infections. More suffering." The word suffering hung in the air like an indictment. Emma looked directly at me. "Dr. Reyes, what do you think?" Everyone in the room turned to me. Dr. Okafor, Dr. Martinez, who'd joined us, Emma and Daniel, all waiting for my opinion. What did I think? I thought about the moment in the OR when I'd picked up Lucas's silent body and decided to fight. I thought about Dr. Chen's warning. "You committed us to a very difficult road." I thought about the weight of Lucas in my hands that first day. Barely there, but unmistakably alive. I thought about the 35 days he'd fought since then. Every crisis overcome. Every setback survived. "I think," I said slowly, choosing each word carefully, "that Lucas has fought harder than anyone expected. Every time we faced a crisis that could have ended this story, he's found a way through. The pneumothorax, the infection, the brain bleed. Every single time." I looked at Emma and Daniel. "Maybe he deserves one more chance to fight." Dr. Okafor nodded. "Then we operate. I'll schedule the OR for this afternoon." The surgery took 4 hours and 23 minutes. I wasn't allowed in the OR. Not my department, not my specialty, not my case. But I waited in the surgical family waiting room with Emma and Daniel, watching the clock creep forward with excruciating slowness. Daniel paced endless circles. Emma sat motionless in a chair, rosary beads moving through her fingers in constant prayer. Neither of them spoke much. I thought about medical school, about the lectures on ethics and difficult decisions, about the philosophical debates over quality of life versus quantity of life, about the papers I'd written on medical futility and patient autonomy. None of it had prepared me for this, for sitting with parents as their child's life hung in balance, knowing that my choice in the OR 35 days ago had led them to this moment. "Dr. Reyes," Emma said quietly, breaking the heavy silence. "Do you have children?" "No," I said. "Do you want them? Someday?" I thought about my parents, about their sacrifices to give me opportunities they never had, about the weight of legacy and hope and responsibility. "Yes," I said. "Someday." Emma nodded, her fingers never stopping their movement through the rosary. "Then you'll understand something. When you hold your child for the first time, everything changes. They're not just a person. They're your whole world compressed into this tiny, perfect being. Every dream you've ever had, every hope, every fear, it's all wrapped up in them. And you'd do anything to protect them." She looked at me with eyes that had forgotten how to sleep, ringed with shadows that spoke of weeks of accumulated terror. "Thank you for fighting for Lucas," she whispered. "Even if," her voice broke, "even if this is all the time we get, thank you for giving us these weeks, for letting us be his parents, for letting us love him." I couldn't speak, could only nod through the tightness in my throat. The surgeon emerged at the 4-hour mark, still in his surgical scrubs, mask pulled down, fatigue evident in every line of his face. We all stood. "He made it through," Dr. Okafor said. "We removed approximately 12 centimeters of necrotic small bowel. The remaining intestine looks viable. He's stable. Critical, but stable." Emma collapsed into Daniel's arms, sobbing with relief and residual terror. The next 72 hours are crucial, Okafor continued. We're watching for signs of infection, for anastomotic leak at the surgical connection sites, for bowel perforation, for sepsis. But he survived the surgery. That's the first hurdle. That's something, I thought. We lived on somethings in the NICU. Small victories, inches of progress, moments of stability between crises. Can we see him? Daniel asked. He's in recovery now, being transferred back to the NICU. Give them 30 minutes to get him settled, but yes, you can see him. Lucas's post-operative course was as brutal as predicted. Within 12 hours, he spiked a fever. Cultures drawn. Antibiotics escalated to cover the broadest possible spectrum of bacteria. His oxygen requirements increased dramatically. The stress of surgery, the anesthesia, the inflammation, all of it hammered his already fragile lungs. A central line was placed in his umbilical artery for better vascular access, for continuous blood pressure monitoring, for the frequent blood draws he needed. He received multiple blood transfusions, his entire blood volume replaced twice over in 72 hours. His nutrition came exclusively through IV fluids. TPN, total parenteral nutrition, carefully calibrated to provide calories, protein, fat, vitamins, minerals. Everything a growing baby needs, delivered straight to the bloodstream because his abbreviated intestine couldn't handle feeds yet. A second brain ultrasound on post-operative day 3 showed the previous bleed had expanded slightly. Not catastrophic, but concerning. The neurosurgery team was consulted. They recommended watchful waiting, intervening only if hydrocephalus developed. Meanwhile, across the NICU, Ethan continued to thrive. By week 6, he was up to 2 pounds 8 ounces. Off all oxygen support, breathing room air, taking small amounts of breast milk by bottle, just a few milliliters at a time, but tolerating it well. Emma could hold him for hours during kangaroo care. Daniel sent photos to family and friends, celebrating milestones that would be trivial for a full-term baby, but were monumental for a micro-preemie. Eyes fully open, tracking faces, responding to voices. But watching Emma with her twins revealed a heartbreaking truth. She'd spend time with Ethan first, smiling, cooing, singing, touching his chubby, relatively speaking cheeks, celebrating his progress. Joy, pure and uncomplicated. Then she'd move to Lucas's isolette, and something would shift in her face. The smile would become strained, fragile. Her eyes would fill with tears she'd blink away. Her hands would shake slightly as she touched him through the portholes. I love them both, she told me one evening, when I found her alone beside Lucas's isolette, crying quietly. I love them exactly the same, but I'm terrified that loving Lucas means watching him suffer, that every day we keep fighting is another day we're hurting him instead of helping him. She looked at her son, still intubated after the surgery, still wired to a dozen machines, still fighting for every breath. What if the kindest thing would be to let him go? She whispered. The question hung between us, heavy and terrible. What do you want to do? I asked gently. Emma stared at Lucas for a long time, watching his chest move in rhythm with the ventilator, watching the monitors cycle through their endless display of numbers, watching the life her body had created struggling to survive. I don't know, she finally said. I honestly don't know anymore. Dr. Webb found me in the residence lounge at 2 a.m., staring at Lucas's latest labs on my tablet. My eyes burned with fatigue, but sleep felt impossible. You're not on NICU service, Webb observed, sitting down across from me. I know, but you can't stay away. No, I admitted. Webb was quiet for a moment, studying me with those sharp, perceptive eyes that seemed to see through every defense. Tell me what you're thinking, he said. I set down the tablet, rubbed my face. I'm thinking that I made a choice in that OR. I chose to fight for Lucas because I believed every life deserves a chance. That survival, even with complications, even with disability, is better than death. But now, I gestured to the tablet, to Lucas's cascade of complications displayed in clinical shorthand. Now I'm wondering if I was fighting for him or for my own ego, my own need to be the hero who saves the unsavable. That's a fair question to ask yourself, Webb said. What's your answer? I don't have one, I said honestly. Some days I look at him and I see a fighter who's beating impossible odds. Other days I see a baby who's suffering because I couldn't accept reality. Then let me ask you something else, Webb said, leaning forward. When you picked up that baby in the OR in that specific moment, what did you feel? I closed my eyes, went back to that day. The chaos, the alarms, the voices overlapping. Dr. Chen's order to let him go. The weight of Lucas in my hands. Almost nothing. Barely there, but undeniably present. I felt like he deserved a chance, I said quietly. Like his story wasn't finished. Like giving up meant I was deciding he didn't matter, that his potential life wasn't worth fighting for. And now? Webb asked. Now I think maybe I was wrong. Maybe Dr. Chen was right. Maybe all I've done is prolong inevitable tragedy. Webb nodded slowly, his expression thoughtful. Medicine is full of moments like this, Reyes. Moments where we make decisions with incomplete information and live with the consequences. You'll have thousands of them in your career. Some will turn out well, some won't. Some will remain ambiguous forever. He paused. The question isn't whether you made the perfect choice. There's rarely such a thing in medicine. The question is whether you made it with integrity. Whether you considered the available information, weighed the options, and chose what you genuinely believed was right in that moment. What if my integrity caused suffering? Then you learn from it, Webb said simply. You adjust your decision-making framework. You do better next time, but you don't abandon the patient in the middle of the story. Lucas is here now. He's a person with parents who love him and medical needs we're capable of addressing. Your responsibility isn't to rewind time and unmake your decision. It's to see this through with the same integrity you brought to that initial choice. Week 8 brought unexpected progress. Lucas's surgical wounds healed. The infection finally cleared after 2 different antibiotic regimens. His bowel function slowly returned, first just moving fluids through, then tolerating microscopic amounts of breast milk through his feeding tube. His weight started climbing again. 1 pound 6 ounces. 1 pound 8 ounces. The brain bleed stopped expanding. Follow-up ultrasounds showed it was stable, possibly even resolving slightly. His oxygen requirements dropped. The ventilator settings were gradually weaned. Lower pressures, less oxygen, slower rate. He's turning a corner, Dr. Martinez said cautiously one morning during rounds. I'm not ready to call it yet, but he's fighting back. His body is responding to treatment. Emma and Daniel began to hope again, carefully, tentatively, like people who'd been burned before and were afraid to touch something warm. But hope, once kindled, is hard to extinguish completely. And then came week 10. I was on night shift, covering the internal medicine wards, when my phone buzzed. A text from the NICU nurse. Code Lucas's isolette. Dr. Martinez notified. Come if you can. I ran. The NICU at 3 a.m. was dimly lit. Most isolettes quiet. Babies sleeping. But Lucas's bay was chaos. Alarms screaming. Nurses clustered around. Dr. Martinez in street clothes, having been called from home, already scrubbing in. What happened? I asked breathlessly. Sudden decompensation, a nurse reported. Heart rate dropped to 30. Oxygen saturation crashed. He stopped breathing. I looked at the monitor. Bradycardia. His heart rate was 25, 20, 15. He's not responding to bagging, another nurse said, manually ventilating him with urgent squeezes. I could see it, his chest rising with each squeeze of the bag, but his body not responding, his color turning from pale to gray. Bag him, Martinez ordered, though they already were. She moved to the isolette, hands already gloved, her face set in grim determination. I grabbed a second bag, took over ventilations. His tiny chest rose and fell with each squeeze, but the numbers on the monitor kept falling. Heart rate 20, someone called. Martinez listened to his chest with a stethoscope, her face darkening. I'm hearing decreased breath sounds on the left, possible pulmonary hemorrhage. She ordered a portable chest x-ray. The image appeared within minutes. Blood. Lucas's tiny lungs were filling with blood. Pulmonary hemorrhage, a catastrophic complication where the delicate capillaries in the lungs rupture and flood the air spaces with blood. Suction, Martinez ordered. A thin catheter was passed down the endotracheal tube. Dark red fluid came back, confirming the diagnosis. Lucas's heart rate dropped further. 15, 10, and then the monitor went flat. One continuous damning tone. Asystole, no heartbeat. Start compressions, Martinez said, her voice steady despite the crisis. I placed my fingers on Lucas's chest, still so small even after 10 weeks of growth, and began chest compressions. The rhythm drilled into me through countless simulations, countless emergencies. Compress, 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 compress. But this felt different from the OR. This felt final. Epinephrine, Martinez called. The medication was drawn up, pushed through his central line. We waited, counting seconds. Nothing. Again, she said. More epinephrine, more compressions. my hands moving in mechanical rhythm on a chest that wasn't responding. 1 minute passed, 2 minutes, 3. Lucas's skin turned from gray to dusky blue. How long? I asked quietly, my voice strained. Martinez glanced at the clock on the wall. 5 minutes! 5 minutes of CPR. Brain damage begins at 4 minutes without oxygen. We were past that threshold. Even if we got him back, what kind of life would he have? But I couldn't stop. Wouldn't stop. 1 more round, I said. Martinez looked at me, and I saw the doubt in her eyes, the calculation, the knowledge that we were likely causing suffering rather than preventing it. But she nodded. 1 more. Another dose of epinephrine pushed. I kept compressing, kept trying to restart a heart that had fought for 70 days. 70 days of machines and medications and interventions. 70 days of pain and procedures and suffering. And I thought, maybe Dr. Chen was right from the beginning. Maybe I should have let him go in the OR. Maybe all I'd accomplished was prolonging his death by 10 weeks, giving his parents false hope before inevitable heartbreak. Dr. Reyes, Martinez said gently, her hand moving toward my shoulder to stop me. I knew what she was going to say. Time to call it. Time to stop. Time to let Lucas go. Please, I whispered. 1 more. Just 1 more. She hesitated, then nodded. I gave 1 more round of compressions, my hands aching, my arms trembling with fatigue and emotion. Squeezed the bag 1 more time, pushing air into lungs that didn't want it anymore. And then, a blip on the monitor. Wait, the nurse said, leaning closer to the screen. I've got something. Everyone froze. Another blip, then another. Heart rate 15, the nurse called, her voice rising with disbelief. 20, 25. Martinez's eyes widened. Keep bagging, steady rhythm. I squeezed the bag in rhythm with his returning heartbeat. Lucas's chest rose and fell. 40, 50, 60. His skin began to shift from blue-gray toward pale pink. Not healthy, but better. Alive. 70, 75, 80. The monitor showed a rhythm. Irregular, fragile, but there. A heartbeat. Lucas was back. Again. For the 3rd time, this impossible fighter had come back from death. Emma and Daniel were called in at 4 a.m. They arrived in the clothes they'd clearly just thrown on. Emma's hair disheveled, Daniel's shirt on inside out. Wild-eyed, terrified. They knew that calls in the middle of the night meant crisis. Dr. Martinez met them in the family consultation room. I stood in the corner, exhausted, still shaking from the adrenaline crash, my hands sore from compressions. Lucas had a pulmonary hemorrhage, Martinez explained, pulling up his chest x-ray on the monitor. His lungs started bleeding. He stopped breathing. His heart stopped. She paused, letting that sink in. We resuscitated him. He's stable now, but she pulled up Lucas's full chart, the cascade of complications scrolling across the screen like an indictment. This is the 3rd major crisis in 10 weeks. The pneumothorax, the NEC requiring surgery, now this. And while he's fought incredibly hard, harder than I've ever seen a 23-weeker fight, I need to ask you a very difficult question. Emma's face was pale, her hands clasped so tightly her knuckles were white. What are we fighting for? Martinez asked gently. I need you to really think about that question and be honest with yourselves and with Lucas. His life, Emma said immediately. We're fighting for his life. His life, Martinez repeated slowly. But I need you to understand what that life looks like right now and what it might look like in the future. She brought up Lucas's brain imaging. He's had a significant intraventricular hemorrhage. It's been stable, which is good, but the damage is done. The likelihood of cerebral palsy, significant cerebral palsy, is very high. We're talking about a child who may never walk, never talk, never live independently. She pulled up his surgical notes. He's had 12 centimeters of small intestine removed. That's a lot for a baby this size. He may develop short gut syndrome. That means lifelong nutritional problems, inability to absorb nutrients normally, potential need for permanent IV feeding. She showed his respiratory status. He's developed significant bronchopulmonary dysplasia, chronic lung disease. He may need oxygen support for years. He'll be at high risk for respiratory infections, for pneumonia, for hospital readmissions. Emma was crying silently, tears streaming down her face. I'm not telling you this to be cruel, Martinez said softly. I'm telling you because you need to understand the reality of what we're doing here. We can continue aggressive interventions, more surgeries, more medications, more machines keeping him alive. We can keep fighting, but I need you to think about whether we're fighting for Lucas or whether we're fighting because we can't accept letting go. The words hit like physical blows. Daniel buried his face in his hands, and I stood there, the architect of this moment, feeling the crushing weight of responsibility. The alternative, Martinez continued, is to transition to comfort care. We remove the breathing tube. We hold him. We keep him comfortable with medication for any pain or distress. We let you be his parents without the barrier of machines and interventions, and we let him go peacefully. You're asking us to choose whether our son lives or dies, Daniel said, his voice raw. No, Martinez said firmly. Lucas's body is making that choice. I'm asking you to choose how he spends whatever time he has left, fighting medical crises or being held and loved by his parents. Emma made a sound like something breaking deep inside. She turned to me, her eyes desperate. Dr. Reyes, you brought him back. 3 times now, you've brought him back when everyone else said to let him go. What do you think? Every eye in the room turned to me. Dr. Martinez, Emma, Daniel. The weight of their expectation, their need for guidance, their desperate hope that I had an answer. What did I think? I thought about Lucas's tiny body in my hands in the OR 10 weeks ago. I thought about the flutter of his heartbeat returning under my fingers. I thought about Emma's words weeks ago. Thank you for letting us be his parents. I thought about Dr. Webb's question. Did you make it with integrity? I thought about Dr. Chen's warning that I'd committed us to a difficult road. And I thought about something else. Something I'd been too proud, too stubborn, too invested to admit. I think, I said slowly, carefully, each word measured, that I made a choice 10 weeks ago based on what I believed was right in that moment. I believed Lucas deserved a chance at life. I believed that fighting was better than giving up. I still believe those things, in principle. I paused, met Emma's eyes. But this isn't about my beliefs. It's not about my need to be right, or to feel like a hero, or to prove something. It's about Lucas, and you, and what's truly best for your son. I took a breath. I can't answer that question for you. I can tell you the medical facts. Lucas has suffered tremendously. He's fought harder than anyone expected. But the road ahead is long and uncertain and filled with pain and procedures and interventions. I can tell you that 25% chance of survival we talked about weeks ago has probably dropped. That even if he survives, his quality of life will be severely compromised. Emma was shaking, her whole body trembling. But I can also tell you this, I continued. Whatever you decide, whether it's to keep fighting or to let him go, both are acts of love. Choosing to fight for every possible day with your son is love. Choosing to spare him further suffering is also love. There's no wrong answer here. Only the answer that feels right to you as his parents. The silence that followed was profound. Finally, Emma spoke, her voice barely above a whisper. Can we have time? To think? To talk? Of course, Martinez said. Take all the time you need. They sat with Lucas. Emma slipped her hands through the isolette portholes, her fingers finding his skin, touching him with a tenderness that broke my heart. Daniel read to him from a children's book in a whisper, his voice cracking every few words. They sat with Ethan too, holding him, feeling the solid weight of their thriving son, the dramatic contrast between the twins, and they talked, quietly, tearfully, honestly. I gave them privacy, but I stayed close, in the residence lounge, waiting, praying to a God I rarely addressed. At dawn, they found me. Emma's eyes were red and swollen, ringed with the kind of exhaustion that goes beyond physical tiredness into soul-deep weariness. Daniel looked like he'd aged 10 years in a single night. We've made a decision, Emma said. I stood, my heart pounding. We want to keep fighting, she said, her voice steadier than I expected. Not because we're in denial, not because we can't accept reality. We know the odds. We know the complications. We know he's suffering. She paused, gathering strength. But Lucas keeps fighting. Every single time we think it's over, that this is the crisis he won't survive, he comes back. He fights back. And as long as he's fighting, we can't give up on him. We can't. But, Daniel added, his arm around Emma's shoulders, we're also making another decision. If there comes a time when he's not fighting anymore, when it's just the machines, when his body is giving up, we'll let him go. We won't force him to stay beyond what his body can handle. Emma nodded. We need you to help us know when that time comes. We need you to be honest with us, because we love him too much to let our fear of losing him cause him to suffer unnecessarily. I felt tears in my own eyes. I can do that, I said. I promise. And one more thing, Emma said, reaching out to take my hand. Will you stay with us? Through whatever comes next? Not just as his doctor, but as part of his story? Yes, I said without hesitation. Absolutely yes. The next 4 weeks were a roller coaster of progress and setbacks. Week 11. Lucas spiked another fever. Cultures were drawn. Different bacteria this time, requiring different antibiotics. 3 days of touch and go before his temperature normalized. Week 12. His oxygen requirements decreased dramatically. The respiratory therapist began weaning his ventilator settings more aggressively. There was talk, tentative, cautious, of trying extubation again. Week 13. He was extubated, the breathing tube removed. For 6 hours, he breathed on his own with just CPAP support. Then he tired, his oxygen saturation dropping, his work of breathing becoming too much. He was re-intubated. The team wasn't discouraged. 6 hours was progress. Week 14. Second extubation attempt. This time he lasted 12 hours before needing re-intubation. Week 15. Third attempt. 18 hours. Week 16. He stayed extubated, breathing on his own with just a nasal cannula. His tiny lungs, scarred and damaged from weeks of mechanical ventilation, finally strong enough to do the work themselves. Emma held him for the first time that day. The nurses helped her settle into the recliner, opened her shirt, carefully, so carefully, transferred Lucas from his isolette to her chest, skin to skin. After 16 weeks of barriers between them, finally just mother and son. Lucas weighed 2 pounds, 3 ounces, still impossibly small, but triple his birth weight. Emma cried, Daniel cried, I cried, watching from across the NICU, this moment I'd fought for and doubted and feared would never come. Lucas opened his eyes, fully now, no longer the fused lids of extreme prematurity. His cloudy, developing vision found his mother's face. Hi, baby, Emma whispered through tears. I'm your mama. I've been waiting so long to hold you. And Lucas, fighter, survivor, miracle against impossible odds, looked back at her. Week 18 brought another milestone, his first bottle feeding, just 1 milliliter of breast milk, a fraction of a teaspoon. But Lucas sucked on the tiny premature nipple, swallowed, didn't aspirate. The feeding therapist called it remarkable progress. Week 20 brought Ethan's discharge. He was 2 pounds, 12 ounces, breathing room air, taking full feeds by bottle. The Cartwright's house was ready. 2 cribs, 2 sets of everything, prepared for twins who would arrive home months apart. The day they took Ethan home, Emma stood at Lucas's isolette, 1 hand on each of her sons, 1 going home, 1 staying behind. I'll be back tomorrow, she promised Lucas, and the day after, and every day until you come home too. Lucas stayed in the NICU, but he kept progressing. His weight climbed past 3 pounds, then 3.5, then 4. His oxygen support was weaned to the minimum, then removed entirely, breathing room air on his own. His feeding volume increased. 2 milliliters, 5, 10, 20. The physical therapist started working with him on muscle development, counteracting the weakness from months of immobility. The occupational therapist addressed his sensory sensitivities, his startle responses, the neurological quirks that might indicate cerebral palsy, but weren't yet definitive. Week 26 brought the conversation about discharge. We're talking about sending him home, Dr. Martinez told Emma and Daniel during rounds. He's breathing room air. He's taking adequate feeds by bottle. His weight is stable at 4 pounds 1 ounce, with close outpatient follow-up, home oxygen on standby just in case, and a clear emergency plan. I think he's ready. Emma cried. Daniel laughed, that half-hysterical laugh of someone who'd given up hope and found it again. When? Emma asked. Maybe another week. We want to make sure the feeding is truly established, but soon. Lucas went home on a Tuesday afternoon in late spring, exactly 6 months after his birth. The NICU nurses gathered around, many of them crying. They'd cared for Lucas for 184 days, 26 weeks. They'd watched him die and come back 3 times. They'd celebrated every ounce gained, every milestone reached, every crisis survived. He's our miracle baby, one nurse said, kissing his tiny forehead. Our little fighter. Dr. Martinez did the final examination, reviewed the discharge instructions, follow-up appointments with neonatology, pulmonology, neurology, gastroenterology, ophthalmology, physical therapy, occupational therapy, early intervention. A team of specialists who would follow Lucas for years. She signed the discharge papers with a smile and tears in her eyes. Emma dressed Lucas in a going-home outfit, still swimming on his small frame, but symbolic nonetheless. Daniel strapped him into a car seat that looked enormous around him, even though it was the smallest size made. Lucas weighed 4 pounds, 2 ounces, still tiny, still fragile, but stable, growing, alive. I wasn't technically supposed to be there. Lucas hadn't been my patient in any official capacity since that first day in the OR. But when Emma had texted asking if I'd be there for discharge, I'd rearrange my schedule without hesitation. I wore my white coat, now wrinkled and familiar, no longer stiff with newness. As they prepared to leave, Emma turned back. "Dr. Reyes," she said, "walk with us?" I did. We rode the elevator down together, Emma holding the car seat, Daniel carrying bags of supplies and medical equipment, me walking beside them. Through the hospital corridors I'd walked countless times over 6 months, past the labor and delivery ward where this story began, past the operating rooms where I'd made the choice that changed everything. At the hospital entrance, sunlight streamed through glass doors. Spring had turned to summer outside. Life continuing, seasons changing, the world turning regardless of individual stories. Emma paused at the threshold, holding Lucas close. "I want you to know something," she said, looking directly at me. "Whatever happens, whether Lucas grows up healthy or faces lifelong challenges, whether this story has a happy ending or a complicated one, I will never, ever regret that you fought for him. You gave us 6 months we wouldn't have had. 6 months of being his parents, of loving him, of watching him fight. That's a gift I can never repay." Daniel nodded, his arm around his wife. "You didn't just save our son. You gave us hope when we had none. You taught us that sometimes the impossible is just the difficult that takes longer." I looked at Lucas, at his alert eyes tracking the movement around him, at the steady rise and fall of his chest, at the tiny fingers curled around Emma's thumb. "He saved himself," I said quietly, my voice thick with emotion. I just refused to give up on him. And honestly, he never gave up either. They walked out into the sunlight, carrying their son home after 6 months in the hospital. I watched them go, then turned back toward the building, toward the wards and the patients and the endless stream of stories still being written. 9 months after discharge, 15 months since his birth, the Cartwrights sent an update, photos of Lucas and Ethan side by side. The twins were starting to look more similar now, though Lucas was still noticeably smaller, more delicate. Both boys were sitting up. Ethan was starting to crawl. Lucas was working on it in physical therapy. Videos of Lucas reaching for toys, his movements a bit slower than typical but determined, smiling at his brother, giggling when his father tickled him. The updates weren't all good news. Lucas had been hospitalized twice for respiratory infections, his damaged lungs making him vulnerable. He'd had surgery to address retinopathy of prematurity before it caused blindness. He was significantly delayed in reaching motor milestones, but he was alive. He was home. He was loved. Dr. Chen found me in the hospital cafeteria one afternoon during my final month of residency, sitting alone with coffee and my tablet, reviewing the latest update from the Cartwrights. "Still following that case?" she asked, sitting down across from me. "Still following Lucas," I corrected gently. "He's not a case. He's a person." Chen smiled slightly. "You're right. My apologies." She gestured to the tablet. "How's he doing?" I showed her the photos and videos. Chen watched silently, her expression thoughtful. "You know," she said after a long pause, "when I told you to let him go in that OR, I wasn't wrong. By every metric we use to make those decisions, gestational age, weight, complications, predicted outcomes, the odds were overwhelmingly against him. Choosing to resuscitate was statistically irrational." "I know," I said. "But you were right too," Chen continued. "Because medicine isn't just metrics and statistics and odds. It's also about recognizing when a patient, even a 1-pound patient who shouldn't survive, is somehow fighting to live, and honoring that fight, even when it seems irrational." She pulled out her phone, showed me photos of her own grandchildren. "I have 5 grandkids now," she said, "and every time I hold one of them, I think about all the babies I've delivered over 25 years, the ones who made it and the ones who didn't, the ones where we fought and won, and the ones where we fought and lost." She paused. "For a long time, I thought the key to surviving this job was maintaining emotional distance, treating each case as a medical problem to solve rather than a human story to engage with." "What changed?" I asked. "Watching you," Chen said simply. "Watching you refuse to accept the statistics. Watching you fight for Lucas not because the odds were good, but because you believed he deserved the chance. It reminded me of why I went into medicine in the first place. Before I got jaded and tired and started seeing percentages instead of people, she stood, squeezed my shoulder, the same gesture she'd given me that night in the NICU months ago. You're going to be a good doctor, Reyes. Maybe a great one. Not because you always make the perfect choice. None of us do. But because you understand that medicine is equal parts science and humanity. And sometimes the humanity matters more. I finished my internal medicine residency that June. During my graduation ceremony, my parents sat in the front row, proud and beaming. Mama cried through the entire thing. Papa took approximately 400 photos. Dr. Webb handed me my certificate, shook my hand, and said quietly, "Remember, every patient is a narrative. Keep listening to their stories." I thought about Lucas, about the narrative I'd refused to let end that day in the OR, about the ongoing story of his life, complicated, uncertain, but undeniably his. That evening, there was a knock on my apartment door. I opened it to find Emma and Daniel standing there with the twins, Ethan toddling on chubby legs, Lucas being carried but looking around with bright, curious eyes. "We couldn't let you graduate without celebrating with us," Emma said. "You're part of our family, Dr. Reyes." We sat together in my small living room, me on the floor with the twins, building blocks for Ethan, sensory toys for Lucas, who was still working on fine motor skills, Emma and Daniel on the couch, watching their sons with the kind of grateful wonder that never quite fades when you've nearly lost something precious. "I got a job offer," I told them. "Attending position in internal medicine at St. Halstead. I'll be staying here." "Good," Emma said firmly. "Because Lucas still has a lot of doctor appointments and we want you at as many as possible." I looked at Lucas, 15 months old, small for his age but growing, facing challenges but overcoming them, alive against impossible odds. "I wouldn't miss them for anything," I said. 2 years after that day in the OR, I attended Lucas's second birthday party. It was held in the Cartwright's backyard, decorated with balloons and streamers, filled with family and friends who'd followed Lucas's journey from the beginning. Lucas was walking now, with a slight gait abnormality that physical therapy was addressing, but walking. His speech was delayed, but he was starting to say words. Mama, Dada, effin, his version of Ethan. He'd had 3 more hospitalizations for respiratory infections. He wore glasses to correct vision problems from the ROP surgery. He received early intervention services 5 days a week. But when his mother brought out his birthday cake and everyone sang, Lucas clapped his hands and laughed. A sound of pure joy that made every struggle worthwhile. I stood to the side, watching, a piece of cake in my hand. Dr. Martinez appeared beside me. She'd been invited too, having followed Lucas throughout his NICU stay and beyond. 23-weekers like him, the ones who make it, they're always fascinating to follow, she said. Never quite sure which way it'll go. Some catch up completely. Some face lifelong challenges. Lucas is somewhere in between. But he's here, I said. "He is absolutely here," Martinez agreed. "And that's because someone, you, refused to accept the statistics as the final word." Lucas toddled over to me, his gait unsteady but determined. He held up his arms, the universal toddler sign for "pick me up." I set down my cake, lifted him. He weighed 20 pounds now, still small for his age, but substantial compared to the 1 pound 6 ounces I'd held in the OR. "Doc Noah," he said, his version of Dr. Noah. My heart melted. "Hi, Lucas," I said softly. "Happy birthday, buddy." He patted my face with sticky, cake-covered hands, then rested his head on my shoulder. Emma appeared with her camera, tears in her eyes. "Can I get a picture?" I posed with Lucas, this child I'd fought for, this impossible miracle, this ongoing story of resilience and love, and the stubborn refusal to accept defeat. The camera flashed. 5 years after that day in the OR, I received a letter. It was addressed to Dr. Noah Reyes, the doctor who wouldn't give up, sent to the hospital. Inside was a drawing, the kind of artwork you get from a kindergartner, all wonky lines and enthusiastic colors. 2 stick figures labeled me and Ethan, a larger figure labeled Doc Noah, and a note from Emma. "Dear Noah, Lucas started kindergarten this week. Special education classroom with support services and accommodations, but kindergarten nonetheless. His teacher says he's bright, curious, and determined. Traits I think he inherited from a certain doctor who refused to let him go. He still faces challenges. His motor skills lag behind. His speech needs therapy. He gets tired easily, but he's thriving in ways we were told he never would. You gave us this. You gave us Lucas's childhood, his laughter, his stubborn determination, his joy. Whatever happens in his future, and we know it will be complicated. You made it possible. Thank you. Will never be enough, but thank you anyway. With love and gratitude, the Cartwright family. I hung the drawing in my office at the hospital, right next to my diplomas and certificates. And every time I faced a difficult decision, every time I questioned whether to push harder or accept limitations, I looked at that drawing and remembered. Sometimes medicine is about statistics and odds and rational decision-making, and sometimes it's about recognizing that every patient, even a 1-pound patient who statistically shouldn't survive, is a person with a story that deserves to be told. Sometimes the right choice is the one that seems impossible. Sometimes refusing to give up is exactly what's needed. And sometimes, against all odds, the smallest fighters win. I thought about Dr. Chen's words that first day. Not every life can be saved. She was right, but some can be. And Lucas proved that the difference between saving and losing sometimes comes down to a single choice, made in a moment of chaos, by someone who simply refused to accept that the story was over. I picked up my phone, sent a message to Emma. Give Lucas a hug from Doc Noah. Tell him I'm proud of him. The response came quickly. He says, I love you. I smiled, feeling the familiar tightness in my throat that came whenever I thought about this case, this child, this ongoing miracle. I love you too, buddy, I wrote back. Then I put my phone away, picked up my stethoscope, and headed out to see my next patient. Because there were always more stories being written, more lives in the balance, more impossible choices waiting to be made. And I would face each one the same way I'd faced that moment in the OR 5 years ago. With integrity, with compassion, with the stubborn belief that every life matters, every person deserves a chance, and that sometimes the right thing to do is simply to refuse to give up, even when, especially when, everyone else says to let go.